antibiotics, but what she hasn't done is gone for the follow-up visit. So if you have something like that, the norm is that you finish your antibiotics and then a few weeks later you go back for a checkup. But she hasn't followed this through. So we're none the wiser as to whether A, she's completed the courses of antibiotics, and B, as to what happened with these UTIs were fully resolved.
But with regard to patient records, what would a healthcare practitioner need to be aware of with patients' records? Privacy, confidential, yes. And something else when we're actually putting results in. That we've got the right patient's results in the right notes so that those notes are accurate. I'm hoping this is also resonating. At the beginning of the module, you did some ethics. Yeah? Governance. This is revision for your MCQ coming up.
Okay, so the next thing is to request some diagnostic tests. Well, the first one, the GP can do him or herself. So, need to take blood pressure, always very handy. Maybe request that the patient has an ultrasound scan because of the previous history of urinary tract infections. Have some routine bread and butter biochemistry tests done, similarly hematology tests. Take both some urine for microbiology, culture and microscopy, and take a tissue biopsy for some histology tests. Maybe make some of the slides that we were doing last week.
What organ might they think about doing the tissue biopsy from? Why? Urine? Yeah. Lower back pain? Sorry? She might have diseased kidney. Okay, thank you.
Okay, so she's going to, there's another important person that's part of the labs here, sometimes associated with GP, sometimes associated with labs, required to take some of those samples. And who's that? What's the profession called responsible for providing us in the labs with some of these specimens? Yeah, that's right, the phlebotomist. Okay.
At the back there, did you hear phlebotomy? Do you know what phlebotomy might be? Or what might it involve? It's the taking of the blood sample, yeah. And the phlebotomist, what key information will the phlebotomist need to ensure when they meet the patient? That they've got the right patient for the request that's been given, so they'll check details with the patient. What else? What's fundamental that the phlebotomist doesn't disclose? Again here, we're looking at data protection. Sometimes phlebotomists come into contact with very important, very famous people. The 42-year-old female might be somebody in the media, in politics, in lots of different guises, but it doesn't matter where they come from. Any health professional needs to be aware that that information is confidential and that data is protected to just taking the blood sample and checking. So it's important that we ensure this chain of confidentiality throughout.
Let's have a look at her blood pressure and her heart rate. What would you say about that blood pressure? Yeah, I know you haven't quite done the cardiovascular yet, not quite yet. It's high, yeah. What's the normal blood pressure?
Is that 120/70?
Yeah, that 120/70, yes, would be normal. It goes up a little bit as you get older, but she's not that old, so we wouldn't expect it to be this high. Now, blood pressure is a funny thing because you can't always relate it to somebody being unwell. What's an artifact that makes your blood pressure go up? Eating? Well, you have to eat, I'm very excited. anxious, and it's quite normal for us if we go to the doctor because we are unwell to feel quite stressed and anxious, and so you have to weigh this up against the results. I remember years ago they had this thing on breakfast television where the Keep Fit guy, they were doing something on blood pressure, and the Keep Fit guy, who's supposed to be fit and therefore have a very low blood pressure, had his blood pressure taken on live TV, and it was through the roof. And this is purely the stress, you know, or the excitement of presenting, and so you have to sort of weigh up these results.
It's like if you took Crystal's and my blood pressure now, we'd probably go through the roof. It's the stress of presenting to you guys.
No.
Well, I speak for myself. She's the professional.
Okay, so the heart rate is also up, got an increased pulse. Again, this might be due to the anxiety, but it might be part of the symptoms. Let's start looking at some of the laboratory results. Okay, so what has happened in the lab before these results have actually been given to the GP to look at? What have we done? What skills have we used in the lab? What have we had to do?
Phosphate's too high.
Phosphate's too high, yes? Phosphate's very high, yeah? How do we know these results are correct, though? How do... Pardon? We carried out the test, but what test did we carry out as well as these? What did we have to do?
No. Think about just these biochemistry results. How do we know these results are accurate?
Compare, not with the normal, but what did I talk about a few weeks ago? You can look at previous history and compare if you're doing it like on a day-to-day basis. Somebody else does it, kind of. Do you remember I talked about we have these materials where we know they're not patient samples, yeah, do you remember? Did it all come back now? Do you remember the name of these samples and the name of that process? Begins with Q, first word Q, second word C. Quality control, thank you very much. Yeah, so to get these results haven't just like been produced like that. We've had to use very many skills before they go out to the GP. We've had to make sure our equipment is maintained, and before we even put the patient sample on the analyzer, we have to run quality control and make sure the quality control is acceptable, and only then do we know that these patient results are analytically correct, and we can send them to the GP so he can help interpret with the other results. So, someone said the phosphate was high. That's right. What else? What else is abnormal? Yeah, potassium, creatinine, yeah? 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 In fact, it'd be far more sensible to ask me just to ask you what's normal, wouldn't it? What isn't abnormal? That's right. It's only the sodium out of all that lot that's actually within the reference range, isn't it? So, it's not doing too well. Go over to Carol, who's going to talk about hematology results.
What do you notice about the hematology results? We've got slightly low red cells and a low hemoglobin. Let's just take the red cells and hemoglobin first. Can we be more specific about what's happening with the red cell and the hemoglobin? Can we define that as a diagnostic term? Anemia. We've got anemia because the hemoglobin is low. What causes anemia? Lack of iron, possibly, because bad diet. But why but that's not what I'm asking is, why are we saying that it's low iron?
Iron is finding hemoglobin.
Iron is carried by hemoglobin. So if if iron is lacking, the hemoglobin is not being formed properly, and we haven't got the red cells to carry them around. So that's the low, okay? The total white count is high. And what do we know about the white cell count, the total white cell count? What's that made up of? What different cells is that made up of? White blood cells, yes, but there are lots of different types of white blood cells. We've got one of them there. Basophils, monocytes, lymphocytes, eosinophils. Okay? We've only got the neutrophils there. It's probably an indication that it's only the neutrophils that were high. Are they high? Okay. So why might we get a high neutrophil count? Going back to okay. Yeah, possibly an infection. So bear this in mind as we go through. Sorry, can I just say one more thing? What are the skills here that the biomedical scientist is using? With the biochemistry results and with these results, what are we using in the way of biomedical skills? Sorry, I didn't catch that. I didn't hear what it was. I heard the test bit, but I didn't hear the bit that came before. Sorry, I'm sorry. I was over there. Elimination tests. Okay, we're doing a battery of tests to actually try and eliminate. Okay, yeah? So these could be termed screening. But what I'm actually looking for is the skills that the biomedical scientist is using. They're doing analytical processes. So they'll be doing some analytical, some practical skills. They'll also be number crunching, looking at the data, checking it against quality control. So they're also looking at analysing data. And knowing, we need a knowledge component here. We need a knowledge component about the type of test, the principles behind the tests, what they show us, but also interpreting the data against quality control. So there's a lot of analytical processes going on here, a lot of analytical skills. Okay. Oh, that's amazing stuff. Okay, last film. I'm sorry, I couldn't get it's not enlarging, but what are these? White cells, you can be more specific.
Neutrophil.
These are neutrophils. This is possibly a lymphocyte. And this is a monocyte. So the total lymphocyte, the total neutrophil count is raised. Within the red cells, can you see these sort of cells here? They're not the nucleus. This is a red cell. These are red cells. They're biconcave discs. But normally we'd expect, if you remember the slide that you looked at when you stayed normal, you'd expect red cells to be well hemoglobinized. Maybe just have a small central dot, because remember red cells are biconcave, and we're looking at them in one unidirection here. But these cells here with this big central pallor area is because of the lack of hemoglobin. There's nothing to latch on to the dye, the colour. So these cells here are hyperchromic, and these are possibly a cell type that would link with an iron deficiency.
Okay. The doctors asked for the patient to give an early morning small pot of urine to go to microbiology for microscopy and culture. But what's a very quick test the GP can do themselves on the urine? Yeah, fantastic. Yeah, everyone that came to the initial tasting sessions, they can just pop in a dipstick, can't they? And even though it's quite crude, it can give some useful information, things that we wouldn't expect. We know certain things we shouldn't be having in our urine, we shouldn't have a lot of sugar, we shouldn't have a lot of protein, we shouldn't have blood, we shouldn't have a lot of cells. So, if we look at the official, the microbiology, two things that happen when urines arrive in the microbiology department. First of all, they just carry out a straightforward microscopy. They just look at a sample under the microscope and they look for cells. Now, you should have less than 2, you shouldn't really have any red blood cells, so what they say is reference is less than 2 red blood cells within the high power field. So they use this term, the high power field, i.e. the area you can actually see at high magnification. So our patient here has got more than 5 red blood cells, and similarly, you shouldn't have any white blood cells either, you should have less than 2, and they've also got more than 5 white blood cells in the high power field. So let's have a look at what these look like. Now, these are, obviously it doesn't look like the blood's mixed, it's just a few cells in the urine sample. But if you look closely, what can you tell me about the shapes of some of those cells? They were smooth? No? What's happened to some of them? Yeah? Yeah, they've got, some of them look like they've got a sort of crinkly edge. That's right, well done, excellent, yes. So when you've got changes in tonicity, then fluid moves. You've done all that work on semi-permeable membranes and cell biology, have you? Yes? So, talking about the movement of fluids across semi-permeable membranes, if the solution is hypertonic, then fluid will move out of the cells and that will cause this shriveling effect. Similarly, the other way round, if the surrounding fluid is hypotonic, then fluid will move into the cells, causing some of them to burst. So there's disruption in the concentration of the urine, causing this. Thank you. And we've also got some white blood cells. You can see they look a lot larger, and you shouldn't see that many. So that's what the urine microscopy will look like.
You can actually relate these, the shape of these cells. You've got the cytoplasm here, and you've got the lobed nuclei. You can actually relate it to the type of white cell, the ones we've just seen. No? The ones that we saw on the blood film.
Yeah.
Neutrophils, yes, thank you.
Now, as well as identifying these cells, there's obviously something there. So they also plate out. Have you done plating out yet? Plating out the cells onto agar, onto a special type of agar. And what's detected is E. coli. Now, where in your body, where would you find E. coli? Yeah, fantastic, in the gut, good. So there's E. coli in his urine sample. Let's have a look at some of the images. Okay, so this is, what stain is this? Have we done this stain? Yeah, well done, it's a gram stain. Yes, this time it's a gram stain for determining, classifying bacteria into gram positive and gram negative. Have we done that yet? Yes, fantastic. So this is a straightforward gram stain, and we can see that there are gram negative bacilli, i.e. the rods. Okay, so that's indicative of E. coli. And let's just look at the plate as well. And this is the company agar, which selects for E. coli, and we can see definite growth. Now that figure, greater than 100,000 colony-forming units per milliliter, is indicative of an infection.
Before we talk about final diagnosis, I just want you to think about the key skills that the biomedical scientists have used here. We talk about the analytical, but but we've added another. What's another skill that both the haematologist and the microbiologist were using? To actually identify the culture and the abnormal cells, or the increase in white blood cells. Microscopy. How many of you can do microscopy? How many of you can set up a microscope and identify cells? So you've got some keys, you're beginning to learn, you've got some key skills that a biomedical scientist would use. What else is linked to that microscopy? Staining. So therefore, what else is linked to that? What skill is linked to that staining? Knowledge. The knowledge, knowing the knowledge of the cells, the bacteria, the knowledge of the stain, the theory of the stain to identify the bacteria, the Gram stain in this case. How many of you know that? So have you got the knowledge that a biomedical scientist would use? Yeah, so have you got this in your e-portfolio? No. Well, are you going to put it into your e-portfolio? So the knowledge of the stain, the microscopy, also knowing where these bacteria are, going back to some of your physiology, knowing what's normal flora in the gut, knowing when things are abnormal, knowing how, when fluid changes, what changes the cells, knowing when your nutrient compound, if you like, is deficient and your cells, your red cells are then affected, and why. And some of that, because she hasn't got any iron, she hasn't got many red cells floating around, could that explain some of her clinical symptoms? Which symptom would that be linked to? The tiredness. So you see there's knowledge here, but there's lots of skills as well. So, you can all make a final diagnosis.
What do you think is wrong with this lady? She's anemic. What do you think? Yes, she's anemic. That's secondary. What do you think the main problems are? Because of all the tests we've done.
But do you think, sorry, can I just look? Do you think, somebody said she's anemic. Yes, she's anemic. But does the anemia cause a lower back pain? No. What might be causing the lower back pain? Infection. Infection of what? If you had an infection, would you get lower back pain? If you had a cold, would you have lower back pain? No. If you had an infection in your kidneys, perhaps. But why? Why does that link to the lower back pain? Where are you? Now your anatomy. Yes? Okay, so are we down to something? So what do we reckon? Full diagnosis, people. She's not pregnant though. Although sometimes some of those symptoms are.
Yes, one.
What have we detected in the urine? She's definitely got a number of. Okay. She's got another infection, yes. She's got another kidney. It's actually in the kidney, but it's actually more severe because of all the results that we've seen across the labs. Her recurrent infections, which she's also got another, which probably weren't resolved properly, have also resulted in her having chronic kidney disease. So she's now also got irreversible damage to her kidneys, which sometimes is secondary to recurrent kidney infections. Not that common, but very severe. And the trouble with chronic kidney disease is once you've totally destroyed some of the kidney tubules, you can't regenerate them. So all we can do is very closely monitor this patient and try and halt the progression, but we can't make her better. So we can do certain things. We can make sure her blood pressure is kept as low as possible, because blood pressure makes the kidney damage worse. Obviously, they can make sure she doesn't get any more infections, and things like a low protein diet also help. Now we're just going to relate the symptoms and our findings.
Couldn't actually upload the slides here, but we talked about kidney, and in the staining practical that you did, you looked at both normal kidney, so you looked at the structure of normal kidney, and you saw the glomeruli, you saw the tubules, and then you also had a slide that was glomerular nephritis, which was showing inflammation. Now, in this patient, if she had a biopsy done, compared to the normal, the glomerular structure would be grossly infiltrated. And where you have that, what stain do we do for the kidney? What stain did you do? What stain did you do for the histology? H&E, well, H&E. Do you want to say that? And the eosin. But the E is the eosin on the H. No, it's the same side. Phenotoxylin and eosin. H&E. That's the same. We don't need H&E and eosin because the E is the bit. So we did an H&E on the for the kidney section. What stain did we do for the blood? We did a Leishman stain. It's part of the Romanowski dyes. Okay, that's it. I just wanted to make sure I didn't miss out histology in our case.
Okay, so you're not actually going to do the kidneys until I think about March next year in Human Anatomy and Physiology, but just to give you the heads up, okay? So these are the kidney is a very, very important organ. That's why people with end-stage renal failure, unless they have a renal transplant or are going to have regular dialysis, they will die, okay? Now, these are the main jobs of the kidney. Quiet, people, quiet, please. Okay. These are the roles of the kidney, and these will account for our findings. First of all, the kidney is responsible for removal of waste products. If we don't remove these waste products in our urine, they accumulate in the blood. So when I showed you the biochemistry results, you saw there was very high levels of something called urea and something called creatinine. Urea is a breakdown product of excess proteins, amino acids, and if we've got too much, the liver converts it to urea, and urea is excreted in the urine. Creatinine is a breakdown product of something called creatine, which is required for muscle activity. So we produce lots of this creatinine every day. We don't need it, we have to excrete it. So those two waste products accumulating in the blood give us an indication straight away that there's problems with the kidneys. The kidneys are very important in fluid and salt regulation, and so you will get either way really. You can get fluid accumulation or you can get fluid loss depending on other symptoms. So we might have dehydration, we might have fluid accumulation leading to high blood pressure. The kidney actually produces two hormones and an active version of a third. So Carol's going to tell you about one of them, which led to one of the results, and if anyone's aware, which hormone is related to the haematology result.
They would tell me.
What do you reckon?
What's the hormone that is responsible for blood cell production, in particular red cells? I'll give you a clue. Begins with an E. Okay. There you go. And if you saw obviously the kidney synthesizes erythropoietin, so if the body's demands for more red cells to be produced, but the kidney is malfunctioning, the level of erythropoietin that's going to be produced is going to be reduced. And therefore you get an anemia resulting. And often in renal patients, they acclimatize or they readjust themselves to surviving with lower hemoglobin. So they kind of acclimatize to a low hemoglobin, and they are what we call chronic anemic patients. And that's why they need dialysis.
The kidney also also produces a hormone called renin in response to low blood volume, which triggers a cascade of hormones which results in the reabsorption of more sodium and less potassium and increase in volume. That isn't apparent in the results. There's no change in the sodium, but sodium is quite difficult to interpret in the blood because it varies according to hydration status. So sodium by itself doesn't tell us that much information. The third hormone, and there's just masses and masses of work, what we're hearing, which hormone is there a lot of research on at the moment and is found to be play an active role in more areas than first thought. To do with sunlight, I'll go to NAG, make sure you get lots of sun on your skin. Why? Vitamin
D.
Yeah, vitamin D, excellent. Okay, now, the active form of vitamin D is formed in the liver. Okay, so when you, it's originally synthesized from cholesterol, and it goes through a stage where one part, if you go to your organic chemistry, there's one hydroxylation in the liver, but this is not the active form. A second hydroxylation occurs in the kidney, and that is the active form. What do you need vitamin D for?
It's for the pump.
Absorption of, yeah? Of what? Yeah, fantastic. So you need vitamin D to absorb calcium. Because you're not getting enough vitamin D produced, the patient's serum calcium is very low because they're unable to absorb dietary calcium. The high phosphate that you notice is because when the body senses that the calcium in the circulation is very, very low, another hormone is produced called, you know, what hormone is it? It's called parathyroid hormone. Okay, so it's produced by the parathyroid gland, and parathyroid hormone, it has a couple of effects. It starts breaking down bone to release calcium into the circulation. So people with very severe renal failure will also start getting bone problems. Okay, they'll start getting easy fractures and things like that. What PTH also does, it reabsorbs as much calcium as it can from the kidneys to prevent it being excreted, but it also allows phosphate to be excreted to prevent sort of binding of calcium and phosphate. So because PTH, one of its roles is on the kidneys, and it can't have that effect, then we're also seeing an accumulation of phosphate in the bloodstream that would normally be excreted by the kidneys. If we were to take some blood gases and measure this patient's blood, we'd find they were slightly acidotic. Okay, there's another role of the kidneys to maintain acid-base balance. You know from your biochemistry that we need to maintain our body, our blood pH at a certain level for what? Yes, homeostasis, for the enzymes to function optimally. So we find that because the kidney is so important in removal of excess protons, then the blood pH will come down, the patient is acidotic, and this also results in an increase in serum potassium because of movement in that cell, which we'll study in detail next year. Kidneys are also very important in the metabolism of some hormones. Insulin, for instance, is metabolized and excreted in the kidneys. When we give people medication, it's very important to know their kidney status because it can lead to accumulating high amounts of drugs in their circulation, and that being higher than you'd expect for the dose, and therefore adverse drug reactions. And filtration and reabsorption. I mean, all those beautiful glomeruli we all saw under the microscope, everything goes through apart from very large proteins, yes? And then most of it is reabsorbed straight away because we need it. We only really want to get rid of the waste products. But once you start getting damage, things that shouldn't pass through the glomeruli do. We start to lose protein. We start to see protein protein in our urine, which we shouldn't do. When we lose protein, the main protein in the circulation is albumin. So our serum albumin goes down, as we saw in the blood results. Albumin is very important in the blood because, as well as carrying various things, it also maintains the oncotic pressure. If you have a low albumin, fluid goes out from the blood vessels into the interstitial spaces, and you get accumulation of fluid, your ankles and your feet, and that's what's causing swelling. Okay? So that swelling is a result of the low albumin. And then we do see disturbances in the sort of incorrect reabsorption and disturbances there. That kind of in a nutshell, I could talk all day about this, but that's your level 6 lecture in when I shall see you then. But I think I shall call it a day now.
I was just going to say, obviously the cells as well as the protein, we saw the red cells and the white cells, so that's also an indication that the kidneys are not working effectively, because we need our red cells, and that also leads to some of these needs, and there's blood being lost unnecessarily. Okay. Just now, just an observation. This case study is part of this module. But very few of you were actually physically taking notes. But you are a lot younger than me, and you've obviously got really good powers of memory. Because you will memorize this and you will know, so that when you get tested on it in your MCQ, it won't be a problem, will it? Because even if these slides appear on the blackboard, which they will, we'll put these up for you. Do you really remember what is going on, what we've discussed today? Can you make the links? Have you got an understanding? Well, I'll leave that for you to find out. I don't understand. My take-home message really is A, I hope you enjoyed this module. It's a module that you maybe not had to work at in the same way as your scientific subjects, but I'm hoping that we've shown you that there is a link across your modules to what you're studying within the course. I hope this has given you some added input now into what you will hopefully gain over the 3 years that you're with us. But I would say, the fact that you've attended is great, because you've attended, you've participated, and that's great. And we'd like this to carry on. But I would say that it is in your interest to take notes, not to rely. Today, all right, you didn't know the case study, so you couldn't really prepare for it. But in some ways, that's neither here nor there. But it is important that you do take your own notes, that you go away and you revise what you've learned, not just from this lecture, but from other lectures, because that's what will keep you sustained. Because with a lot of your modules, well, apart from 3 modules this year, most of your modules are running year-long. The module material that you've met this semester, you may not revisit next semester. You will link, but you will be learning new material every time. It is a phenomenal amount that you have to take on board, but you need to have an understanding of that. So it's important to prepare, to attend, to participate, but more importantly to go over and revise those notes and link them to what you're studying, so that you then become prepared for the exams and you keep